Thanks to the organizers for the opportunity to talk today. Starting with my declarations, but I need to emphasize that views that I express in this talk are my own. So this is what I selected to cover in the talk today. Tony has made my job that much easier by giving a good introduction to the disease. So I will talk about the serotype epidemiology in children, particularly looking at invasive pneumococcal disease, which is the best quality data that we've got for pneumococcal disease. Look at the schedule that we have for infants here, particularly in terms of whether we've got it right, because we had a schedule change, as many of you know, in 2018. I'll show some data from the assessment that we've done to look at that impact of the schedule change, and then mention a bit more about the new PCVs, which again, Tony has already introduced, the PCV 15 and 20, which have been recently registered for use in children as well in Australia and in a number of other settings. What we could expect in terms of clinical benefit and methods of inferring clinical benefit from immune responses, because immune responses is what we've got to look at clinical protection from these vaccines. So this figure pretty much summarizes the story of PCVs in children in Australia so far. So this is showing rates of invasive disease calculated using IPD notifications to the National Notifiable Disease Surveillance System. And the different colors show rates by different serotype groups. And the top black line is total IPD. You could see the events that are relevant for PCV introduction in Australian kids. So PCV 7, we had the universal program started in 2005. We changed over to PCV 13 in 2011, and then the schedule change we had from the 3+0, long-standing 3+0 schedule, where we gave 3 primary doses at 2, 4, 6 months of age, to 2+1, where the third primary dose became a booster dose at 12 months of age. A few things I want to draw your attention to. So obviously there's that reduction in total IPD during the COVID years. We all know about that. But if you look at that pink arrow, that's the lowest point that we got for total IPD post PCV. So that's 1 year after PCV 13 introduction. So if you like, that's the nadir that we got of total IPD. And then thereon, there's been an increase in total IPD cases or rates in children. And that is contributed to by these non-vaccine type increases. So if you like, serotype replacement, which is that green line. And then there's residual PCV 13, mainly serotype 3, which causes about 1/4 of the disease now. So and the other thing I want to show, draw your attention to is that the rate in 2023, you can see that it's above what it was prior to when we started the PCV 13 vaccine. So pretty much that non-vaccine types and serotype 3 disease has offset the gains that we had from the 13-valent vaccine. So where to from here for PCV in kids is the question to ask. So a bit more about serotype 3 disease. So some clinical features of serotype 3 disease. So this is from data that we collect of pediatric patients, all IPD cases, clinical data across these 4 hospitals. So Sydney Children's Hospital, Children's Hospital Westmead, Royal Children's here in Melbourne, and John Hunter Hospital. So this is data for those 4 years, 2017, 18, and 2021. We had 200 odd cases, and of that, about 1/4 were due to serotype 3, so similar to the national data. So in terms of the clinical presentation, large majority of them were pneumonia for 40 out of the 47. and a lot of them had complicated pneumonia. So many of them had empyema and also some other complications like pneumothorax and so on. A lot of them healthy children without any underlying risk conditions. About a third ended up in ICU, and about 2/3 had associated viral infections, either antecedent or concomitant diagnosed as well. So moving on to showing some of the assessments of ours, looking at what the dosing schedule did, the change in the dosing schedule did. So this is showing you again, based on IPD notifications, the breakthrough cases in children who has received 3 doses of PCV13. So that's vaccine type disease in children who have received 3 doses of PCV13. So that's the colored portions of those bars, and the full height of the bar shows total IPD in children who are eligible to receive 3 doses of PCV13 from program commencement. So the things that I want to note here are those colored portions of the bars gradually increasing from 2012 onwards. So the breakthrough case counts increased once we had introduced a PCV13 vaccine, which wasn't seen with PCV7. So that was, and you could see that those breakthrough cases were accumulating in the toddler year age group. So those second and third years of life, so the red and green portions of the bars. And that was the main reason for that change in that schedule to have a booster dose to assure more protection in the toddler years. And that we see happening. So in 2019, you can see that a red portion of the bar is narrower than before the schedule change prior to 2018. And in 2022, you can see that the green and the red bars both are narrower, which means that there is better protection into the toddler years with the 2+1 schedule. So this is our analysis trying to tease out what's happened with the schedule change, removing the effect of the COVID, pandemic restrictions. So here we had looked at incidence rates of breakthrough cases in a cohort of children who are eligible to receive the 2+1 schedule versus a cohort of children eligible to receive the 3+0 schedule previously. And we removed cases in the pandemic years. So the thing to note here is that if you look at the top row, for all serotypes excluding serotype 3, there's a 50% reduction, and that is statistically significant. For serotype 3, there is no real difference, and therefore there is no real difference in total breakthrough cases, breakthrough case rates in the two cohorts. So moving on to commenting a bit more about what to expect in terms of clinical protection from these new PCVs, PCV 15 and 20. So as Tony mentioned, following the development of this highly efficacious PCV7, doing placebo-controlled trials to measure clinical vaccine efficacy for new PCVs were not ethical or feasible. So fortunately, there is an accepted correlate of protection to infer clinical protection in children for new PCVs. And that was possible because there were both vaccine efficacy and antibody level data from the same population from PCV7 efficacy trials. And I won't go into details of how this correlate of protection was developed, but that Cyber et al. Paper in 2007 describes that method. So basically, they had these reverse cumulative distribution curves, that as the one that's shown in that slide, that plotted the antibody concentrations in children who received the vaccine and placebo recipients, and use the vaccine efficacy estimate from that trial to develop this IgG concentration, which corresponded to the vaccine efficacy, the known vaccine efficacy, which is 0.35 level that is now considered as the correlate of protection against IPD, regardless of the serotype for the vaccine PCVs. So again, Tony did mention some of these as well. So this correlate of protection based approval of new PCVs is based on this non-inferiority to the licensed product, and we assume that if this non-inferior immunologically, that would equate to similar clinical efficacy. So PCV 13 and 10 were assessed against PCV 7 based on non-inferiority, PCV 15 and 20, which in their trials had PCV 13 as the comparator, was assessed using immuno non-inferiority to PCV 13, which in turn was licensed based on immune non-inferiority to PCV 7. And so for PCV 15 and 20, what we've got is a bridge-to-bridge approach. And the risk of that is this downward drift of efficacy, where the third vaccine could be accepted despite having inferior immunogenicity to the originally licensed product. So, and the other thing to note here is that I said that for PCV7, what we had was a aggregate correlator protection. So it was for all serotypes combined, but more recent data like this study from the UK showed that the correlator protection actually varies by serotype. So what they did in the UK, this Andrews et al., was that they created these reverse cumulative curves using antibody concentration data from PCV13 trials, and then applied PCV13 vaccine effectiveness estimates for individual serotype to look at correlator protection for each individual serotype. And that showed that there was significant difference between those correlates, and they also differed from that 0.35. So for instance, if you look at those red circles for serotype 3, it's about 8 times higher than the 0.35 level, and for serotype like 6A, it's about half of that 0.35 level. So which means that aggregate correlator protection is likely imprecise. So showing you this data from one of the PCV15 trials, looking at the schedule 2+1 schedule, which is the one that majority of the children currently get here. So this is showing you the proportions above that 0.35 threshold for PCV15 and PCV13 recipients. So comparison, if you look at the column on the far right, for 11 of the 13 common serotypes, PCV15 had lower immunogenicity, so those minuses you could see there. But for serotype 3, the proportion was much higher, and whether it would translate into superior clinical protection is to be seen. So similar data for PCV20 compared to PCV13. Proportions above 0.35. So again, I need to note here that for few of the serotypes in this trial, they used a cutoff slightly lower than 0.35. So 8 of the 13 common serotypes, PCV20 proportion was similar or marginally higher. PCV20 was lower for 5, and it was worse for serotype 3. And for serotype 3, did not meet the non-inferiority criteria. So this data that I just showed indicates that so clinical benefit inferences for PCV15 and 20 needs to take into consideration the variation of the antibody levels by serotype, as well as the variation of correlator protection by serotype. So one way to do this is to apply the cyber method in reverse, as shown in that graph there. So you can create those reverse cumulative curves using antibody responses from PCV15 and PCV20 trials, and then combine that with serotype-specific correlator protection from studies like the Andrews et al. Paper to predict vaccine efficacy or effectiveness by serotype for each PCV15 and 20, particularly the common serotypes with PCV13. Then use those serotype-specific vaccine effectiveness estimates to calculate reductions in disease weighted by relative burden of vaccine serotypes to estimate expected clinical benefits for these new PCVs. So very quickly want to show this slide from the ACIP, US ACIP, where they presented this work looking at cost effectiveness of PCV20 versus PCV15. So the main thing I want to highlight here is that they looked at the various influential inputs to their cost per collie assessments. The most influential input was a reduction in disease in adults, which is mediated by a reduction in carriage. And it is not surprising, but the challenge there is that it is hard to predict what these new vaccines would do to carriage in children, because for one thing, we don't have a correlate of protection for carriage. And if we did have one, that would be much higher than what is there for IPD. And then other influential inputs there are non-IPD outcomes, for which, again, we don't have correlates of protection. So I will finish with this one. So this is the situation with PCV 15 and 20 for children at the moment in our country. As Tony mentioned, both these vaccines are TGA approved. So initially it was Vaxneuvance, the PCV 15 vaccine that was TGA approved in January 2022. And more recently, PCV 20 has also been now approved for use in children. It's not NIP funded yet. It's available in the private market, and you can see the price per dose in the private market there. What does the Australian Immunization Handbook say? So ATAGI recommendation. So PCV 15 ATAGI says to use that in children as a non-preferential alternative to PCV 13, and they are only interim recommendations. So ATAGI is currently undertaking, as the handbook says, a comprehensive review of the optimal pneumococcal vaccination program. In terms of the PBAC approval, so that is what you need for them to be, these vaccines to be eligible for publicly funding on the NIP. For PCV 15 and PCV 20, they both are eligible to be listed on the NIP, but as Tony mentioned, these have been deemed cost-effective on a cost minimization basis to the comparators 15 and 13. For 15, 13 variant vaccine, and for 20, it was 13 and 15. So I will stop there, and happy to take any questions if there is time.
Sanjay, thank you. Are there any specific questions for Sanjay, and then we'll start the panel discussion?
Yeah, thanks, Sanjay. It's a great talk. So I'm Catherine Satsky from MCRI. And I think one of the points you came to at the end is very critical about the level of antibody or other immune correlates needed to protect against carriage, critical for herd protection. And I guess some of the published and also unpublished data I've seen is that I guess it's like preventing disease, there's big variations in serotypes. So I think it will be a very complex picture as these high valency come on board, vaccines, as well as, whole cell vaccines or protein antigens, how decisions are going to be made in the future.
So, I fully agree. I'll probably take that as a comment. And there have been, studies where they had tried to sort of estimate correlates of protection for different outcomes. And, it's much higher for, as I said, for, less severe disease as well as for carriage.
Sanjay, thank you. I'll ask, yes, please.
One very quick question. How much does the cost? Just by way of comparison to the other two on your last slide.
So in the private market, I'm not sure, Katie, that's a good question, but it is, NIP funded. So probably, people.
Yeah, I'm just thinking this cost minimization question, and I wasn't sure how much
it
actually costs.
And then, so this is what I showed you for PC 15 and 20 are the costs in the private market. So for PBAC, probably the cost would have been different. So
yeah,